Okay, my esteemed colleagues. So, we're as population health scientists, when we think of the health of women and girls, we first consider the influence of the social determinants. This is what we do. The presence of the COVID-19 pandemic, however, has added significant urgency in this last decade for realizing the 2030 Sustainable Development Goals. This morning, this panel will have a robust discussion of the link between these determinants and the health of women and girls. So I'd like to begin with you, Dr. Kondraty, Shrikant.
Yep.
You and I just, with a group of others, just had a successful policy brief, which was delivered through the T20, the Think 20, which was delivered to the G20. And we actually figured heavily, this policy brief was on health as a global public good, and verbatim or words were put in the consensus document that went forward to the leaders. So hopefully they'll pay attention and listen. Let's talk a little bit about health as a global public good and the implications for women and girls in the COVID-19 response, recovery, and beyond.
Sure. So thank you, Dr. Yonet, for giving me this opportunity to speak and share some of my thoughts on this. Yeah, indeed, you are right. So we recently have contributed to Think 20 policy briefs, and then that was taken into the consideration by the T20 communique. And then these ideas were put forward to G20 leaders who met recently in Riyadh in Saudi Arabia. So to start with, as we have stated in our policy briefs, that health is a global public good, and then our proposition was taken into consideration, and then the T20 communique has stated that the health is a global public good, reaffirmation of health as global public good, which is being done. So what we mean by global public good in a more generic way. So global public good is something which is non-rivalrous and non-excludable. That means excludable means no one be denied of getting some health access or health product access, and non-rivalrous mean that, so even if community consumes that health product, that should not limit the access to the other people. So that is the very generic definitions of global public good for health. That means non-rivalrous and non-excludable. So that means everyone should get access to the medicines or vaccines, whatever that we produce, especially in the context of COVID. So we are hoping that, as we know that we are very soon going to get some vaccines for COVID. So their vaccine is, of course, should be made accessible to every single individual. And then the coverage itself is the critical point. Even once we have the vaccine, so we have to make it available to each and every single person on Earth, on the planet, of course, I know stage by stage or step by step to cover these things. So this is where I can see an important role coming up for the women and children, because so they are the critical people, because women are the frontline workers in many of the countries, especially in global South. So they are the critical drivers to make this coverage happen. So that way I see they have a very strong and potential role to play in this global health space, and then making these vaccines available in terms of universal coverage of vaccines, COVID vaccines. So that's what I'm looking forward to.
Excellent. Thank you, Shrikant. So, and we'll obviously come back to you with questions. Lillian, NCDs are a critical factor in the economic viability of women and girls. Here we have COVID-19, and many of those conditions have been exacerbated. We're already trying to get NCDs and on, if you think of the global South, layer COVID-19 on that, and we're hearing about the concomitant results. Tell us a little bit about the implications for women and girls in the global South in particular.
Yeah. Thanks for that. And just to reflect on NCDs in general, we know that globally, the NCDs actually cause a lot of deaths. And unfortunately, even if most of the cases are in developed countries, about 85% of the deaths actually occur in developing countries. And they cause a lot of deaths among the 30 to 70 years range, which means that those are a productive age. And the deaths range from 10% in developed countries to 60% in low and middle income countries. So you can see how disproportionate that is. Speaking about my context, which is Kenya, NCDs actually account for 27% of the deaths, and definitely affecting productivity, economic growth, and trapping the poorest in chronic poverty. Women tend to be affected more, not necessarily by the disease itself, but the diseases and the need to take care of their families and the financial implications of those kinds of disruptions. The most common NCDs we talk about in the LMIC setup are cancer, diabetes, hypertension, cardiovascular disease, mental health, and violence. And yes, we've seen how all those have come up a lot in COVID, in the case of COVID, but we've not necessarily seen the urge or the government's focusing on addressing those in the long term. So specifically, I'd like to focus on the two issues that affect women the most at the economic peak, and those are cancer and violence. So for cancer, using Kenyan statistics, the leading cases of cancer in Kenyan women are cervical cancer and breast cancer. Cervical cancer can be prevented, and there have been programs on doing that, but the reach is very, very low. There's very low, for example, screening. Now we've talked about a vaccine and hardly being used or taken up, and actually facing barriers from religious leaders and others who are opposed to it. So again, that tends to affect women a lot more. And turning to the issue of violence, violence is ranked as the 9th highest cause of mortality in Kenya. And for women, it's specifically gender-based violence. And we know from the statistics that about half of the females would have reported some form of physical violence in their childhood between 13 and 17 years from a recent violence against children survey. And around 16% have reported sexual violence before they turn 18. So we know that it's a big issue, and it does affect the mental health and the economic ability of women as they grow. So there's a lot more to be done, and we know that there are gaps in looking at this and looking at how exactly do NCDs affect women? How do they affect the economic viability? And there's a lot that needs to be done that we can discuss today. Thank you.
Yes. Thank you so much, Lillian. Very particular issues and issues of the vaccine that have been raised by people in the global north without the understanding of what's happening in the global south. And of course, we're talking about the HPV vaccine. So thank you. So let's pivot briefly next to Lisa Jones. And, we didn't do introduction and bios, but we'll talk about that later. We're all population health scientists, and I just rolled into substance. But Lisa, I would love for you to share with this group your recent, this presentation at the TEDx Santa Barbara, Making Waves, around the twin epidemics of COVID-19 and racism, et cetera, disparities impacting women and girls. You were talking primarily in the United States, but I know that you have some reference to the global south.
Yes, and again, thank you, Dr. Thomas, for having me here. As the WAIG Global Health Lead, I think it's important to make sure that we truly identify the experiences of what's happening with women of color, both in the US and of course in the global south. So as one can imagine what's happening now with the COVID-19 pandemic, there's a lot of gaps, there's a lot of disparities that have been raising in the surface. And before, it was mostly information that was made available or known or studied by a number of healthcare scientists, public health officials. And now this is rising to a population level where you're seeing some snippets, if you will, some stories, some experiences in social media and even in news outlets. And what I think is so paramount right now is truly understanding what I would deem, and again, not a new concept here, is the double emergencies that are impacting women of color. And what do I mean by that? Well, there is certainly a number of risks with regards to, if you will, the implied and then less subtle, if you will, or more subtle experiences that women of color face in the healthcare system, or in terms of delivery of care, or how they even access care, if you can imagine. And so before, particularly in the US, women of color had a different experience with regards to their interaction with healthcare professionals, with regards to the healthcare experience, and thus their outcomes of those experiences than, say, their white female counterparts or even their white male counterparts. And that's reflective of a number of things. I speak one highly with regards to health, and that's looking at cardiovascular issues, particularly with regards to hypertension. In fact, there is a report through the Office of Minority Health that speaks to this in terms of the rising rates of women who are at risk with regards to hypertension, and then issues with regards to obesity. There's also, in terms of risk to life in general, with regards to maternal deaths, and that is well known globally. That would also be mostly inclusive of the global South. And just to highlight, if you will, with regards to UNICEF data, they highlight that in sub-Saharan Africa, that the women there have the highest level of maternal mortality rate, in which about 533 maternal deaths are per 100,000 live births. And that's something to really take into account. I think it's really important to understand that it's quite paramount, and it needs to be brought up to the surface. In terms of other, if you will, double emergencies with regards to health, is overall, if you just think of things that were happening before the pandemic, how it's now exacerbated, if you will, now, these are the times in which we need to make sure we lend our voice and our actions to help close those gaps.
Thank you so much, Lisa. Patricia, you are one of the leaders in the world of innovations to improve healthcare for women. You're part of that Duke family, and you guys are doing amazing things. Talk to us a little bit about adapting healthcare innovations to improve the health and the care of women and girls.
Thank you so much, Dr. Thomas. Yes, so I think one of the, let me start off just by citing some recent work that we concluded at the beginning of the year. We were running a 2.5 year accelerator called the ACE Lab, which is Accelerating Saving Lives at Birth, which is really taking a cohort of gap-filling healthcare innovations focused on women's and girls' health that had received funding from the Grand Challenges for Health, both Grand Challenges Canada, USAID, the Gates Foundation, and a number of funders, and really trying to see how we could push them to really move from, from ideation, from validation into the market, and to integrating a sustainable scale. And so we worked with this, 40-something different innovations focused on Africa and India primarily. And I think one of the challenges that we found is that, while this is an important area, where innovation can play a huge role, it has been challenging for a lot of these technologies and delivery models, but especially novel technologies, to be able to integrate into existing health systems in low and middle income countries. And so just the aspect around creating an enabling environment that focuses investments, as well as reorient staffing models and workflow processes towards amplifying the benefit from this gap filling potential innovations has been such a challenge. And another team at Duke actually did an evaluation of about 9 years of investments in innovations that focused on women's and girls' health. And one of the challenges was that over this 7 to 9 years of sustained investments, there was never clear metrics of success. How do you tell that a healthcare innovation is succeeding in terms of actual outcomes that benefit women and girls? And so that continues to be a challenge to our community. And I think in light of COVID-19, as we look for new technologies, new advances in the vaccine and other related areas, the issue of metrics and evidence of success will continue to be a challenge.
Okay, thank you. Metrics and evidence for success. So on that note, Joel, you're in the business of leveraging AI and digital technology to deliver access to quality healthcare for women. Given what our colleague Patricia just said, talk to us some about what's happening in your world and what what it is you're trying to deliver on the continent and beyond. You're muted. So you have to unmute yourself.
Yeah, sorry about that. Yeah, hello to everyone. I would have said good morning, good afternoon, good evening, but with different time zones. So thanks for having me on board, Dr. Thomas. So what have I been doing? There's quite a bit that's been happening. As you're all aware, the pandemic actually created a situation where other health-related issues were prioritized behind the pandemic. Now, in sub-Saharan Africa, especially, you find a situation where things like immunizations fell off the window, going to see the doctor was quite difficult or non-existent, except in the cases of emergencies. You have health screenings all falling off in terms of not being done at all. So recently, I was invited to speak to discuss the sort of things happening with fellow panelists at the Future of Health Summit, the CNB Africa one, and we're focusing on how do we accelerate this whole digital health technology. What I'm finding out more and more is that the solutions are there. I think we have to start looking at a willingness to really do something about it, because we tend to talk about the challenges and everything. And of course, in sub-Saharan Africa, because these solutions have not really been delivered before COVID, it's now become worse. So now we're having a situation where we've gone a few steps back to even get things forward. So one of the key things I'm advocating is a digital first approach, where we look at how do we ensure that wherever possible we digitize, because the challenge we have is lack of data. And as Patricia mentioned a few minutes ago when talking about having the metrics to really check on progress or to really find out the efficacy of any of these solutions, we can't have it without data. And then we have to look at collaboration between all the players in the healthcare ecosystem. Excuse me. Because the healthcare ecosystem has quite a number of, you have the government agencies, you have people like ourselves who are healthcare solution providers on the tech space, you have yourselves who are population and public health epidemiologists and everybody. But we have to start looking at on what are we working on together and what are we working on to move forward? Because it seems like most of the time there are discussions and everyone is quite conversant with what the challenges are. But I think I would like a situation where we're moving towards what solutions can we be talking about that are working, because you have solutions working in isolation in some various parts in Africa, but they're not at scale. And let's just take the best of breed from all these various solutions and come together as a collective to look at how do we now build a solution to move things forward. So in my view on what I've experienced so far, I'm getting quite a lot of discussions with health talking about how do we move things forward, but there's a huge gap. The huge gap is within their workforce not being digitally ready. And so they also have to upskill and reskill their workforce. So what we are doing in Send Health now is we have a health technology course, Introduction to Health Technology course, which we've developed. It's going out next week. And we have customized versions of those courses for some organizations which we're speaking to, and we're delivering that to the healthcare workforce. While we're doing this, it's important that the workforce is actually digitally sensitized into the solutions that what can happen, because even if you on the leadership level provide a digital health strategy and you're thinking of what to do, it can't work without you taking everyone along. So digital first approach is what we're looking at, and also education and upskilling of health workers as a collective.
Great, thank you. Right on the button there. This is so, it's amazing when we have these conversations coming together. And I don't know about you guys, I get all excited when I'm hanging out with my posses, people like you, because we're really in sync and it's all coming together. And what I mean by that, in listening to you, it made me think of my dear friend Sandro Galea at Boston School of Public Health. And he recently said to me in a conversation, says, Yanette, to create health, we need to create a world around us that generates health. And when I think of what we're doing and the work we all are doing in very varied ways in LMICs, this is really the crux of it. And I think what you said, Joel, about the collaboration among the players in the healthcare ecosystem. So let's talk about that a little bit. Shrikant, we talked about global public goods. We need to recognize those, but we also have to have that collaboration. Patricia's looking for the data and the innovation. Lillian is out there identifying and getting people sensitized at the community level to the issues of NCDs. And Lisa is looking at the panorama of these twin epidemics. And it's interesting that maternal comparisons of maternal deaths in the United States among women of color marry and reflect what's happening in LMICs. So when we think of the global north, it's a layered look. So let's have a conversation about that. There's a lot I said in there, but let's take it apart and together. Lisa, you look like you were anxious to say something. Yes.
No, I mean, what you're saying resonates with me. And I think what's quite fascinating is, and to add to what Joel speaks of, is the data is there, or the data is beginning to build up, or if you were beginning to grow it. And I think it's important for us to begin to connect those dots, those data points, to understand those stories, and really to pull out the compelling pieces that can help move the needle, so that indeed the health of the women, if you will, in this scenario is improved and then is sustainable. Because what I think is most paramount right now with regards to the COVID-19 pandemic is there is, if you will, a response to the pandemic. There's a response to the public health crisis. And we're moving towards how to manage that, the sustainability, if you will, and then that path towards recovery. And why could we not do the same thing in this forum?
Okay, yes. Lillian, you look like you were ready to hit your button. You're on mute, yes.
Yeah, so I think it's a very good point, and some of the points that have come through are quite critical. And I'm just reflecting on the point of data and how everybody has put it. Even when you look at what we do and NCDs or communicable diseases, the key gap that we see is having data that is gender disaggregated that can be used to make decisions. So when we're looking at things like NCDs and we're saying there's hypertension or cancer, but we're not looking specifically at who's most affected, is it women or men, what's affecting this group more than the other, it makes it difficult to then plan or program or even do advocacy for funding that can help that. And it even makes it difficult to help with what Patricia and Joel are doing in terms of the innovation. So that for me is a key aspect that we need to look at. And it even goes to how do we look at it in our setting? It will be gender and vulnerability and other factors, or even informal urban settlements versus rural versus the more urban, more wealthier neighborhoods. So that for me is a big aspect in terms of looking at women's health and the over that agenda. Thanks.
Yeah, it's interesting that you mentioned informal and urban settlements. Shrikant is aware of this. I and a bunch of colleagues, including Shrikant, we just launched Urban Health 360. And for those of us who are in the urban health space, we're not excluding rural health, but we know that by 2050, more than 90% of the world will be living in urban communities. And the greatest growth is happening in Africa and in Asia, even more so in Asia than in Africa. And we know what those urban settlements look like. I've worked in Bangladesh. Oh my goodness, we've been in Nairobi, you've got Kibera and all the notables. The reality is infrastructures are not ready for people coming into primary and secondary cities. And we have this concomitant overlay of the health of that population. And so bringing this together, as Shrikant coined in our group, urban health is a microcosm of global health. And we really have to think of what all these pieces mean. And in fact, as I listen to you guys, we're piping up to go back to the T20 with another policy brief. And I think, Shrikant, we have the co-authors here. We're lining it up because this is really in terms of when leaders are looking at the issues impacting LMICs, the global south, even cities in the global north, this ecosystem that this healthcare ecosystem that Joel referred to, it doesn't only mean the innovative aspects, the wonderful pharmacies and that, but the health of the population. How is that being responded to, along with the innovations are helping us to respond to that? So with that, I'd like to ask Patricia to give your salt on this, your flavor on this conversation.
Yeah, thanks, Yonet. Yeah, I think a lot of things as well have resonated. I recall there's a recent article from The Lancet in August that said, COVID-19 has had a devastating effect on women and girls. And I think it especially called out, the challenges around access to care, especially for preventive and promotive health services. And I think, as you speak around, some of the factors, especially in informal urban settlements. It's not just the infrastructure in terms of broad infrastructure, but even the health infrastructure that basically is not well set up to be able to really promote access to preventive and promotive health services. And I think because of some of the fears that our populations have had in terms of going to healthcare facilities, we've lost a lot of ground. Especially on reproductive health, family planning, because then these are almost seen as, second tier sort of services, because I'm not sick, why am I seeking preventive promotive services? And so I think, this is one of the areas that we'll really have to focus on, how to reclaim lost ground around, preventive promotive health, and especially how to use proven innovations in terms of patient engagement, in terms of reaching people where they are at, as opposed to, our health systems that are often, if you build it, they will come, but really more focusing and being more patient-centric. And I see healthcare innovations, especially those that have a layer of patient engagement and, community engagement, being really critical in helping us reclaim that lost ground.
Absolutely. And, COVID-19 has been, as morbid as this sound, is an opportunity, because we have to prepare for the next and the next and the next pandemic, which will be coming. Shrikant, give us a little bit of insight into bringing this together in the context of global public goods.
Well, I'll give you a quick example here. So the example is from India. I would take the accredited social health activists. In short, we call them as ASHA workers, who constitute almost 1 million women-centered. Women constitute that ASHA group, and they're almost like a 1 million population who are at the center stage of the this healthcare responses in India, including COVID. So I'm seeing that in the recent past, they were overloaded with already the work they are doing for healthcare services. On top of it, they were engaged in this COVID response. Indeed, they were very successful, but they were not. There were lots of reports coming up. They were not compensated. So, and I'm sure in many countries, there are similar such arrangements and mechanisms, women being part of the healthcare services and making these products accessible, healthcare services accessible. So when it comes to coming back to the point of global public good, so as we're envisioning, so the vaccine is on the way, and the coverage is critical. And as I said, in India's case, so the ASHAs are again critical in coverage aspects of the vaccines. So, and I guess similar such women engagement in healthcare services in other countries. I'm not quite sure how the other countries are being providing or helping these healthcare services providers, especially the women who are delivering these services. So if they are paid, if they are compensated for their services, that could be one aspect which motivates them to be part of this response and then recovery process. So I think the national leadership would be emphasizing on this point of compensating the extra burden that women are being taking part in this process.
Great, thank you, Shrikant. I just want to take this opportunity now, we're at 11:31, to open it up for questions, and then I come back to the group for us to kind of the so what do we do kind of question. members of the audience, are there any questions from you? You'll have to unmute yourself for the panelists. Any questions for the panelists? And when you unmute yourself, please show your video so we can see who you are. Everyone's quiet. Nobody has a question. Okay. All right. Going once, going twice. Okay. All right. With that, I want to ask my colleagues here. So we know this. We've got Lancet writing about this. We've got stuff coming out of Brookings. We've got, we do TED Talks. We do policy briefs, all of this. What would be, if we were asked, the group of us, what would be the come together scenario, taking away from this conversation that we're having today, of the so what, given what we know, given what we talked about, given the Lancet papers and everything, if we were thinking in the context of the ecosystem, the healthcare ecosystem, disaggregating gender data, the informal settlements, the metrics, the twin epidemics, and this whole issue of, I'm particularly interested, Lillian, in this cervical cancer link to women and girls, linked to violence, because some violence experts argue that the very experience, the trauma, physical and mental, of violence in child and as girls, particularly sexual violence, leads to issues and an environment for cervical cancer. And invariably, it's the same perpetrators who argue that girls should not get HPV. So it's this circular engagement interaction. What would be the so what? And I'm going to go to each of you. If we have to come together, we're going to go to a group. What would be the thing you would say, we should target this and focus on this? As you well know, we write about them and we get, who do we get to listen to this? Who should be hearing this? Who wants to go?
Well, maybe I can take first stance here. So as we know that the data that we are having and the information that we are having, so there is only 1 in 8 countries have the appropriate legislations to protect the women and girls against the social and economic impacts. So it's obviously when it comes to the protecting women's rights and children, I mean the girls, so against violence and all these things, and it's obviously the legislations which matters most, as the data shows that the 1 in 8 countries have these legislations to protect them. So it's obviously the nation leaderships who need to take care of these things, and obviously going for appropriate legislations moving forward. So that's the way forward, I think.
Great, thank you. Good.
And I'm sure that, so as I said, it's 1 in 8. That means most of the global South countries probably would not have or may not have these legislations. So it's obviously, again, the prerogative goes to the global South countries to legislate more concrete and tangible acts or pieces of laws.
Okay, thank you, Shrikant. Lillian.
Yeah, so I think, and thanks, Yonette, and interesting conversation and discussion. So one of the things that for me comes through, and we've kind of talked about it, if we use that human-centered design approach and we think of that most vulnerable person, that most vulnerable woman, and what does she need for looking at it holistically, would be able to make a big difference in terms of all those different facets of life that affect women and girls. And we, my background is mostly around HIV. And one of the things that has come through, even from the HIV angle, is that we have to avoid the silo approach where we've looked at, okay, how do we prevent HIV only? And yet the challenges affecting women are so cross-cutting and so connected. So if we look at the woman and girl holistically, and we all give whatever we can and kind of have a woman's movement sort of thing, where if we're looking at HIV, we're also looking at the maternal mortality issues, the reproductive health, violence, the cervical cancer, then we'll be able to really address those needs. And in that context, we'd also understand what is the community she comes from? How do we deal with that community so that we can start changing those negative gender norms that mean that a woman cannot access health services, even if they are provided, or is limited in terms of being able to afford to pay for those services. So for me, that's the key aspect of ensuring that we have that human-centered focus from the community level up to the top leadership. Thank you.
Yeah, I agree with you. It's so critical because I've always been frustrated as an epidemiologist dealing with maternal and child health. It's critical, but then we get caught up when we talk about women in LMICs. It's all about sexual and reproductive health. But you have to see the woman as a whole. That's an important part, but you have to see it as a whole. And so we get into these political alleys where our funding, I was at the National Institutes of Health, so we'd fight over whether it's a conservative government in the United States, the funding alleys for, well, we're not funding contraceptions. That's not what it's about. It's about the health of women and girls, right? Holistically. So I agree with you wholeheartedly. Lisa, what would you say?
You know, you bring up a very interesting point here, and I think it's to really walk it back, meaning instead of starting from the starting point of the girls and women, I would take it a different angle. And if you will, I guess, fast forward, if you will, or look ahead to the future. With regard to the healthcare workforce, it's feminized. I believe it's about 70% or even greater, if you will, in terms of the healthcare workforce, depending on the nurse, community health worker, etc. They are women. And so if you can think about it from the perspective of in terms of your economy within your nation, within your country, if you do not protect these women and offer them services from when they are a girl, then how will they be able to populate your continued workforce again if it's at 70%? So what I mean by that is your hospitals are impacted, your healthcare centers, your primary care centers are impacted if these women are not taken care of as girls then. So in terms of the whole life course of the woman being a girl from an adult, to have those provision of services, you have to look at your workforce. And I think that will be the, if you will, not necessarily the carrot and stick approach, but if you want to really look at it as, so what does it do? What is the impact to me? What is the impact to my nation, my country? I think that's a starting point, or at least part of the dialogue that needs to be discussed.
I love it. I love it. Yep. Yep. So it's almost as if we have to create a wheel. What are these? Yeah, and think about it. So it's the holistic wheel. I really like that holistic, and it's much needed. Patricia, how would you respond to this?
Yeah, no, I definitely agree with all the points that have been raised so far. I think one of the things that Shrikant talked to is this aspect of unpaid labor. I think in the healthcare space, when you think about community health workers or volunteers, but I think the pandemic has also really just lifted the lid on, just the amount of unpaid labor that women perform all across, the economy. And I think because of, the fact that, women's, economic input is maybe valued less, sometimes means that their needs and, the issues that affect them sometimes get devalued. And linking this with a recent piece of work that we released at the end of October, where we are looking around the COVID vaccine procurement and how there are major inequities between, the availability, just even on pre-purchasing between upper middle income countries and lower middle income countries. And right now we're really looking at it at a national or at an economic level, GDP level. But what I'd love for this group to advocate is, let's disaggregate that data further. When the vaccine comes through, who is going to have access? How do we make sure that this group of individuals that often performs, vast amounts of unpaid labor within the healthcare workforce at home and elsewhere have the same chance of accessing this life-saving technology? and innovation. I think that's definitely something that we should put on the table.
Okay, wonderful. Joel, thank you for that. Yes, Joel, sorry. I was busy writing. Yeah.
Yeah, it's okay. Okay, yeah, that's fine. No, Lillian raised an interesting point. She was talking about NCDs and saying there's about 27% of deaths in Kenya, right, Lillian? And when you look at management of NCDs, and also when we look in addition to that, that the healthcare workforce, as Lisa mentioned, 70% or more women, you see the actual impact in the management of that directly. And then we look at cancer, breast cancer. I was in a meeting, I think last week with Lisa and Abimbola and some other, I think Alice, we're talking about the kind of dashboard and what we could do. And you find out that cancer, breast cancer is on the rise, especially during this period because of the COVID pandemic. So I tend to be, because I'm such, my space is in technology, as you very well know, but I've been in project management for years and I'm so focused on deliverables and doing. So I want to propose 2 solutions we should look into and see what can really happen. There are 2 ways to tackle this. It's a very, very big issue to resolve. And we have to look at the influence we have as a group, if it's really strong enough to really make a change. Then you look at how the diverse geographical areas you have to implement this solution. We can take the approach of looking at strengthening the data, because we know data is weak. Even though we're having data coming out, it can still be strengthened to such a point that we can now dissect that data and create impact analysis. Then we start getting the soft insights Patricia spoke about, the insight Lisa was talking about, and Lillian, and what Sirikant was talking about when we're looking at it in rural areas. What can we do? Then we can draw inferences and create policies from there. That's one aspect, and it's quite big as well. Or we could look into what sort of digital solutions are available, because they are available right now, that we put in there. Take, for instance, we talk about cervical cancer. There's this device, a portable device by Mobile ODT. I think I mentioned it last year when I was at the conference, and I had a discussion with some of the head of that unit sometime this year. We're talking about looking at a project on that. And with the mobile colposcope, what you can do is that untrained people can actually go and do this cervical cancer screening and all those sort of related things. Even you have Philips releasing a handheld portable imaging device for doing this sort of CT and scans and these other things you have to do. So what I'm saying by this is that we're getting to a point where there are affordable solutions that we can create and look into how do we get that into the community level, because at community health level, and looking at targeting the community health workers and the nurses, which are predominantly women, and creating a sort of flagship health screening thing focused on women and moving that forward. Now, to do the advantage of doing the latter, the one I'm talking about, is that you can create your data points and everything, lets you access the data. The advantage of the first one is that you could now say, should we influence at municipal levels? Should we influence at government levels to help to introduce these programs and then introduce data? So I think that we have to really start looking at what are we really going to do concretely, and where does it fit in that it can have scale? Because without scale, we end up like most other people who are well-meaning and have done very important and very good things, but they've done it in isolated places and not at scale. And I think that's where the challenge is for Africa. We are not able to do things at scale because we have people working in little silos, delivering within an area, and we don't have visibility of what each other is doing.
So let me push you on this issue of data, because we collect a lot of data. We know survey data are not that informative because it's household level and it takes years. So the demographic health surveys, they're good, but they're nice in the backdrop. But we have health departments that collect data. Patricia, you can talk more about this. We have organizations like your Duke Collaborative where data are collected. Is it that we have no data, or is it that the data are siloed what's the issue? What's the data issue? And because when you talk about data, you know, we spend billions of dollars. I mean, at the National Institutes of Health, and I can talk about that experience, you know, we fund all these projects, and each one of those projects produce data, but they're sitting in somebody's office somewhere, and it's valuable data. So is it a mining of existing data, or in the context of, let's just say, Africa?
Okay.
There are no, or there is no, if you think of it collectively, data that we can reliably link to determinants, to outcomes, to really
Exactly.
to tell a wholesome story. Is that the issue?
Well,
I'm going to hold on you for a minute, Joel, and I'm going to go to Patricia because she's in the heart of this stuff.
Okay.
And then you, Lillian.
Yeah. I know Joel is so passionate about this.
Yes,
issue.
I know. I love him for that. Yes.
Yeah. And so I think because a lot of healthcare innovations do rely on data, have ended up moving away from sort of thinking about this from the entrepreneur's perspective to thinking about this from the policymakers, you know, from the producers of data. And so trying to understand, you know, what are the challenges? So a bit of it is, well, a lot of it is really around, you know, interoperability, that you have data in systems that aren't speaking to each other, and those linkages, you know, this idea of the data commons, where you have aspects of data about, you know, around the individual, you know, in nutrition departments, in health departments, you know, in ministries of planning, but then those linkages are not really being made. And a lot of it also is around governance, you know, data governance. How do you create trust that allows exchange of information between, you know, these silos that Joel talks about, whether they are within countries, around sectors, or between countries. So when you think about, again, the COVID pandemic, when you're thinking about the idea of a health passport, you know, how do countries assure that people who are coming in, you know, have either received the vaccine or have been tested? How do you allow, you know, that interoperability of data, just from a very fundamental fact? And we spent about maybe 4 years working with 2 different regions in Africa, one in the Horn of Africa, as well as the West African region, trying to use regional platforms to try and get countries to think about, you know, that there is value in, you know, data speaking a common language, embedding trust that allows exchange of information. And I think we are making progress. So within the Horn of Africa, we are looking to have a policy validated in February. In West Africa, they are taking a different approach with the West Africa Health Organization, starting sort of being the sort of silo of trust, or sort of being the unit of trust and engaging member states. But I think it's definitely one of those aspects that it's really not as the absence of data, but you know, the enabling environment and the fundamental building blocks that allow that data to really be useful. Over to you, Joel.
Okay, so before we go to Joel, let's go to Lillian, and then I'm going to pretend to be Joel. I'm going to channel Joel for a little bit. So Lillian, I'm writing, sorry, data enabling environments. Yes. What are your thoughts on this data issue?
I think we have a mix of both in terms of too much data and too little data. Too much in terms of as you rightfully put it, government has always been collecting data. It's paper-based, it's in registers that just pile up, sometimes in offices, and in some cases they've managed to put it in electronic form, but sometimes getting access to that is a bit problematic. So even if you wanted to get national level data and you want to go to the ministry, the bureaucracy might not allow you to get that data. And sometimes it's too little in terms of, now when I was talking about the disaggregation, for example, by women or by informal settlements, like when we wanted to get specific data for Nairobi County on the informal settlements, they don't actually collect data in that form. So they don't have that data to inform them and show who is being left behind, because they look at Nairobi holistically, and it's the widest range of socioeconomic status that you can imagine. And then on the other hand, we have a lot of researchers. There's so much research that has taken place in, say, Kenya.
Yeah.
And most of it ends up with the researchers. And especially when they're from the global north, it just ends up with them. It's not used locally. It's not, in fact, the research is done without government involvement. So it doesn't benefit the locals. try and change any policy. And the drive now is to ensure that you're working with government through the government systems, and that you translate that data or that evidence immediately into some policy or practice.
Yes, and I just want to speak to that before I start channeling Joel, and then Joel, I'll let you have the last word. That is an important point. And Patricia, I hope your policymaker engagement includes that. When I was in NIH, I had a $90 million budget. And I know all of those people who were saying they're going to do stuff in Africa. We did a lot of HIV stuff, blah, blah, blah. It's sitting in their university offices, and that data that we write great papers and books and we make names for ourselves. And then the data are not used for the people and by the people. So that's something for policymakers to really, national policymakers making their data, you're coming in to collect data, leave it in the country in a form that country researchers can use it and we can have it as part of a larger database. So I'm channeling Joel now. I'm an entrepreneur. And I am all this, we go to these, Africa Health business meetings that I find very frustrating because they don't talk about people. They talk about in all these mechanisms. And we want to do something. We're innovators. We've got AI, we've got these platforms, we're ready to go. Just let us cut through and get to some information. Okay, give us some data. Maybe we can do a pilot and we can show the value of taking this to scale. How would we do that in your context, Patricia, in the context of what you spoke of? Joel wants to come in and he's got a bunch of buddies and buddies that including men and women who are ready. They're the smartest minds of Africa. They're into digital, they're in AI, and they got Japanese money and they're coming. What do you say to them?
I think it's to what Lillian said. It reminds me of a conversation we're having with policymakers from Kenya, Ethiopia, and IGAD, that essentially, you have to start with scale as the end goal. And so, it's great that you have this great idea, but how do you make sure that you are integrating it from the beginning into the context of the health system? And so a lot of what we do is make and facilitate connections and make them aware in terms of, this is the context, this is the ecosystem, this is the lay of the land. These are the public sector priorities. How do you align with those? And then also, how do you make sure that you are under the governance of, the Ministry of Health, for example, in Kenya has a technical working group that vets or screens some of these pilots and some of these ideas and investments. And how do you make sure that you're under that singular governance system, as opposed to sort of running off and because you have the investment? And so for us, a lot of this has been, have scale and sustainability as the end goal, and then figure out whether is this able to be integrated into the existing health system in a smooth way that does not disrupt, healthcare workflows, does not disrupt, provision of essential services. So those bigger system issues, which I think as, being a champion of entrepreneurs, sometimes you're not really thinking about system. You're just thinking about your thing, your wonderful novel solution. So I think for us, it's really reframing this into more systemic thinking.
Okay, on that systemic note, Lisa, you're also involved in health informatics. What is your take on this before we give Joel the last word?
For the opportunity. I think what's resonating right now, and this is a term that I learned from my medical colleague in the US in the healthcare system, and that is that we are data rich but information poor. And I think to what Patricia just said now, I think it's important to understand that the data that exists currently, we need to have a means or a mechanism to translate that, to make that meaningful to the population that we're supporting, the population that we're serving. So it's great that we're collating, it's great that we have this information, what information that we do have. And again, it's important to leverage it from a gender perspective. But again, how does it get down to the population in particular to drive that change, to drive that action? And I think that's something that, as long as we keep that as a focus and we bring that, if you will, to the stakeholders, I think then we will be able to measure success.
Okay. Yeah, it's a big task. Joel, you get the last word. So, and part of having the last word is that you got to come up with an idea for a project that we can all work on building all this together that delivers on what you want. If you had your ideal, what would you do? You got the last word.
Okay, so just before I answer that question, just quickly to talk about this ecosystem, because Patricia mentioned interoperability, which is a problem. And also Lillian was talking about a lot of information there that is there, but we can't get it. And Lisa was talking about where data rich but information poor, which is true. One of the key things we can look into is having a health information exchange, a platform, a HIE platform. We've not really focused on looking at that. Neither are we talking about open data and open data policies. Now, one of the things that scares me the most when we talk about AI, IoT, and all these things in the context of Africa is that most times we're looking outside the continent for solutions. But these solutions have actually been trained on data that is not on the continent. So we're not going to have those solutions working in the best interest for us. So until we start a digital first approach, that's why I'm quite passionate about that. We're not in a position to start even doing AI related projects that will impact African specific health related challenges. That's one. So we have to really, if we're going to make a move, I know that there's the excuses of, and I use the word excuse because maybe entrepreneurs are impatient of government, this, that, all those things. Let's look at WhatsApp. WhatsApp started off with just text. If you remember, let's look about 5 years ago. If you had my phone number, you will text me and you ask, is it okay to talk on WhatsApp before you will call? And people were not really calling. And then WhatsApp moved into groups. People were a bit hesitant. Now everybody has a WhatsApp group. It's so interactive and everything. And guess what's happened? During COVID, WhatsApp usage was so much up that doctors were using WhatsApp for their patients. Now WhatsApp has end-to-end encryption. But unfortunately, what's happening? You have a data-rich WhatsApp communication with your doctor because you can't integrate that data into your electronic medical record system or whatever. So what is happening here is that patients are becoming empowered whether we like it or not. And if we're going to seize that empowerment, we should focus on patient-generated health data because patients are using fitness devices. They're using, for instance, in Said Health, we have linked devices for companies where we link your blood pressure device into a mobile app for them, white label that, and also the Center for Diabetes. Now, if you start focusing on training and also educating patients, because a lot of people use WhatsApp communication for text and also videos, it's a game changer. So I feel the solutions are there. I think we have to really, as a collective, say that if we're choosing a project, we're committing that. What exactly can we do? And as Patricia said, it's important that you think scale in mind. So where can we plug in? So I think the first question to resolve this is looking at where can we plug in a proposed solution that the probability of having scale is very, very high. And what goes from there.
And on that note, that leaves us, I like it because it leaves us wanting more. It's 12 noon. And in a year's time, I would like for us to come back and say, you know, we were talking about this back in December, November, and here's what we were able to, here are the 2 steps we were able to take in that direction. So I want to thank you all, my esteemed colleagues. This was riveting. I just love this because, you know, this is what churns and this is what keeps us thinking and the generations behind us. Our call to action is to come back next year and see what we were able, the 5 of us were able to do to move just a little bit. We don't have to do a big thing. Move that needle, just a kung. Okay? Thank you so much. Thank you, audience, for listening. And with that, it's a wrap.